My name is Alli. I am an interventional cardiologist with Novant Heart and Vascular Institute in Charlotte, North Carolina. I want to thank the directors of CVI for inviting me to give this talk on aortic malposition as part of the CVI virtual meeting 2020. I have no disclosures for this talk. Aortic malposition is defined as the displacement of the new transcatheter heart valve into the ventricular or aortic position without obvious embolization. It's a less common complication of transcatheter heart valve procedures. It can be seen with both self-expanding and balloon-expandable prosthesis. I'm going to illustrate this concept by showing two cases. The first is a case of an 80-year-old man with severe low-flow, low-grade aortic stenosis, with markedly reduced LV function and known CAD. He underwent transcatheter aortic valve replacement with a 34mm Evolut Pro plus prosthesis. What you see here in the angiogram is the deployment of the core valve prosthesis, and upon release of the valve, what you notice is that the valve moves ventricular just immediately after release of the last time of the valve. And the consequence of this displacement into the ventricular area was significant aortic paravalvular regurgitation, which is shown on the next slide. Here you see an angiogram that shows significant aortic insufficiency. This was confirmed by TEE, which shows a fair amount of aortic insufficiency around the new valve annulus. Obviously, this was not a good situation, and we had to do something about it. The next case is that of a 75-year-old female with severe prosthetic aortic insufficiency. She had a history of aortic valve replacement with a homograft several years prior and had known moderate LV dysfunction. She's had recurrent heart failure symptoms and was deemed high risk for reduced TAVR due to her comorbidities. Here we see a 26mm Sapien 3 prosthesis being deployed, and the valve slipped into the ventricular, more ventricular, and following valve deployment, we noticed significant aortic insufficiency also. This is shown here on this slide here, where we see an aortogram showing significant AI here. And once we took out the wire, we confirmed that she did have significant aortic paravalvular leak. And the question became, what should we do about this issue? The etiology of valve malposition could be several. It could be lack of significant calcium in the valve leaflets and annulus. It could be because of significant angulation between the aorta and the LV. Examples with patients with horizontal heart, especially when you're using a large self-expanding prosthesis. There could be a significant discrepancy between the LVOT and the aortic annulus in terms of diameters or dimensions. In situations where you have a much larger LVOT, the valve could slip ventricular as the LVOT flares out. If you use transcatheter heart valves in homografts, it's a little more challenging than native annuluses, and they are severely calcified. Usually the valve leaflets are degenerated because homografts usually fill with aortic insufficiency. Sometimes the valve does not grab as well, and it could slip ventricular or even aortic in some situations. And lastly, off-label use of the transcatheter heart valves. If you're using it to treat aortic insufficiency without significant valve or annular calcium, you could end up having a valve that may go ventricular or aortic. And if you're using it to treat aortic insufficiency in patients with pre-existing valves, where the valve kind of sucks the new valve ventricular, that can be a problem. So those are the common scenarios where we see aortic malposition. What do we do about it? The most important consequence is development of severe paravalvular leak. Obviously, if a malposition valve is not dealt with properly, it could obviously embolize. It could embolize aortic or ventricular, depending on what valve you're using. But options for treatment could be balloon dilatation, where you try and expand the transcatheter valve with aggressive balloon dilatation to anchor it properly and hopefully reduce paravalvular leak. You could snare and reposition the valve. Obviously, you could put a new transcatheter valve in the existing valve, or in all fails, you may have to go the route of surgical aortic valve replacement. Snare repositioning was first described in 2010. You could use several techniques. You could use a single or double snare technique where you grab the tines of the new transcatheter heart valves. It's been described with the use in self-expanding prostheses. You can use a single snare from the radial or femoral axis, or a double snare using a combination of radial or femoral axis as desired. The goal is to be able to pull the heart valve more aortic and thus anchor it properly and reduce perivalvular leak. Potential complications include valve embolization. You may pull too hard and the valve now moves into the aorta. You could have aortic trauma as you pull the valve, and you could end up with a CVA with the release of debris from all the pushing and pulling. That's a risk of having a stroke in this kind of scenario. So one has to be really careful. If you cannot perform snaring and moving the aortic valve into the aortic position with reduction in PVL, the next best option is to do TAVR-in-TAVR or TAVR-in-TAVR, which is a really good option. Here we see a 29mm SAPIEN 3 prosthesis being deployed into the existing Evolut Pro Plus with excellent results. So that's a good option. Obviously now you've used 2 transcatheter heart valves, but otherwise this is probably better than converting a high-risk patient into a surgical case with more morbidity. This is also a TAVR-in-TAVR for the earlier patient that we talked about, where we put a new 26 SAPIEN 3 into the existing prosthesis, and that really took care of the problem, and the follow-up angiogram did not show much aortic insufficiency. In conclusion, aortic malposition is an uncommon complication of TAVR. The consequence is usually the development of severe aortic paravalvular regurgitation. It may lead to valve embolization if not properly managed. Management strategies include balloon dilatation, snaring and repositioning, transcatheter TAVR-in-TAVR, and surgical intervention. Thank you.